I'm Dr. Mark Swain, hepatologist from the University of Calgary in Calgary, Alberta, Canada. AASLD was the phase 3 study which led to elafibranor being approved to treat as second-line therapy in PBC patients who had failed URSO therapy. And so we know that treatment with elafibranor for 52 weeks, which was the AASLD study, was effective in improving the biochemistry and having people essentially respond with regards to second-line treatment, and also improve their symptoms. And the symptoms they're mainly focused on were pruritus and fatigue. However, with the end of that study, there was a continuation of treatment essentially, and so those individuals who rolled into that long-term follow-up were followed for up to 3 years. And so the question really is, are these improvements sustained? And so what this study has shown is that when you follow people out to up to 3 years, the biochemical improvements that we see are sustained, that they continue and maybe even slightly accumulate more with regards to the biochemical response. So the people who had actually had a symptomatic improvement, so improvement in their fatigue as measured by PROs that are widely used to evaluate fatigue, or by PROs to evaluate itchiness or pruritus. When you follow those patients out for up to 3 years, in fact, not only are those symptom improvements maintained, but actually over time it appears that there's actually even an increase in the number of people that have a beneficial effect from these therapies. So this is very encouraging, that when we start people on treatment, when they get their biochemical response, we know that if they stay on their therapy, it's going to be sustained long term, and they're going to get a long-term benefit from that treatment with regards to biochemical endpoints. But we can also now talk to our patients about symptomatic and symptoms, and targeting symptoms in a way that we can improve them, which many of these symptoms we had no tools to really treat them before, or tools that were somewhat inadequate, like for pruritus. And we can start people on therapy, and we're confident that if those symptoms improve, that not only will they be sustained, but they'll actually, it looks like over time, they'll actually continue to get even better. An interesting part of the AASLD study was a proteomics unbiased assessment of changes in proteins that happen with treatment with elafibranor. And this has not been done in any treatment, any second-line treatment that's been used to treat PBC. And what happened in this part of the study was serum samples were collected, so blood samples, at the beginning of treatment, at week 26 in the AASLD study, then at week 52 of the study. And those samples were sent to a special to a laboratory where a special test was done, and that special test basically uses a very sophisticated technique, and in a very small sample of blood, they can look at over 5,000 proteins. So it's not looking at one protein or two proteins; it's looking at 5,000, and then they look at them at baseline, and then at the end of treatment. And the idea is, without guessing at what proteins might change, just look at what proteins change in individuals who respond to elafibranor treatment. So essentially, at the start of treatment, so just before they get treatment, and at the end, and you'll have people that have placebo and people that are treated with elafibranor. So in the people that had symptoms, so whether it's pruritus or whether it's fatigue, they were also assessed with regards to using patient-reported outcomes. So they had, at the same time points, they were assessed for how they feel. Are they itching, and how much is the itch, and how severe is their itch, and how much does it impact their quality of life? And these questionnaires that were used are validated questionnaires. There was 3 for itch. And then with regards to fatigue, there are also validated questionnaires that can be used, and they were also administered at the same time points, and there was 2 of those, and one was a disease-specific one, so specifically for PBC patients. The other one is a widely used one that was developed by the National Institutes of Health called a PROMIS scale. And that scale has been widely used in many different diseases: inflammatory bowel disease, lupus, many different diseases. So so what they did was they looked at the proteins and they said, well, what are the proteins at baseline, so before treatment, do they correlate with any of these symptoms? And what they found was that there was proteins that came out of this analysis that have been associated with itch, although not commonly. So kind of surprisingly, they came out and they were shown to correlate with itch. And that also, when you looked at response to elafibranor, so people who had a what would be called a biochemical response, and that's called the POISE criteria, which means that their biochemistry improves to a certain level where you say they're a responder and they're going to get benefit from that drug. Those individuals actually had an improvement in those proteins that are associated with itch that matched many of the assessments of itch as measured by the PROs. So this is really a novel way of looking at proteins that you wouldn't even expect but have been implicated in a symptom like itch, and that they change with treatment with elafibranor in a way that is associated with benefit with regards to itch. And the same thing was applied to fatigue. So they measured fatigue at baseline at the end. And at baseline, what they found was it was a core group of proteins that were changed, and those proteins almost all suggest that the mitochondria are not working properly. And the mitochondria are like the energy engines of cells. So when they're not working properly, that's commonly associated with fatigue. So in long-term fatigue syndromes like long COVID or chronic fatigue syndrome, one of the signatures people see is that in their blood they have changes in proteins which suggest that mitochondria are not working properly, or changes really directly looking at mitochondrial function showing that it's not working properly. But it's not just in the blood. It also, because fatigue comes from the brain, and so this is like a marker in the blood that tells us that something's happening in the brain that's linked to mitochondrial function, which causes them to have a symptom like fatigue. And so what they found was at baseline, PBC patients who had fatigue had abnormalities in these proteins which go along with mitochondrial function. And when they were treated with elafibranor and had a response, the change in those proteins, so an improvement back towards normal or becoming normal, because normally you shouldn't find those proteins in the blood, really, or at a high level. Those improvements in those proteins was associated with patients saying they had less fatigue on their questionnaires. So on the two questionnaires that we used, the one that was disease specific and the one that was a general one that was used in many diseases, showed significant improvements in those symptoms that correlated with those changes in protein. So this is very exciting because now we have potentially biomarkers for symptoms. And so we don't really have those. And so when someone's sitting in front of us, when you sort of project this into the future, in an optimistic future, can we measure those proteins? Is that part of risk stratifying patients? Can we actually use objective tests, like we look at an alkaline phosphatase level and we use that to stratify people? Can we now stratify people with regards to these changes in the blood proteins? Can we develop assays that could go along with that, simpler assays? And then we can follow them and we treat. And so we can follow the symptoms that people feel, but we can also follow changes in these biochemistry, which is going to, I think, really help us not only understand these diseases, but actually care for patients in a much more holistic way.